Thank you for joining our webinar hosted by Psychology Specialists of Maine Center for Education. My name is Dr. Julie Quimby, and I am founder and CEO of Psychology Specialists of Maine. It is my pleasure to introduce our speaker, Dr. Robert King, who is our lead psychiatrist and has joined us to help launch the Center for Psychiatry here at PSM. Dr. King completed his 4-year residency in psychiatry at Maine Medical Center after graduating from the Columbia University School of Physicians and Surgeons. It's my pleasure to introduce Dr. King, and I will turn it over to him.
Everyone, I'm glad to be seeing many of you who I haven't met. And it's funny to be actually attending my first Lunch and Learn as a presenter, but I plan to become a regular attendee in the future. And this topic has the potential to be a heavy, polarizing, politically unsettled topic, but I hope to make it less so in your interactions with clients. And it's certainly important and feels exceptionally relevant right now, although it's hard to think of a time, any time recently, when it hasn't felt relevant and important. So I titled this talk, Trigger Happy, Debunking Myths and Examining Realities of Mental Health and Gun Violence because of the intense frequency of gun violence across the United States and the association commonly made between these acts and mental illness. My goals are to review epidemiology of how Americans are impacted by firearms. I'd like to discuss what is known about the relationship between mental illness and gun violence, and in doing so, I want to dive into the most common types of gun injuries. I'll briefly explore psychological symptoms which are associated with violent behavior and the psychology of people who attempt mass shootings. And finally, I want to discuss how a clinician might work with patients to reduce risk of injury from guns. This is a vast topic, and I apologize for what I'm not able to cover today. So what drew my attention to this subject is really that firearm-related violence is impossible to ignore, and particularly the mass shooting events which propagate waves of fear across the country each time they occur. Here's a map from the Gun Violence Archive, and it shows the numbers of shootings by firearms in different regions of the country just so far this year, as of this past weekend. There have been 13 mass shootings just since November 1st. The recent shootings in Maine were the deadliest in the United States so far this year. Another reason for this talk is that there's a public perception that mental illness provides a causal relationship for gun violence and that people with mental illness are considered dangerous, and I wanted to explore the validity of that public concept. Some of the anecdotal myths about the relationship between gun violence and mental illness include that mental illness is a leading cause of violence, that if mental illness or clinicians had the right screening tools, we would be able to prevent and predict violence. Discussing firearms with suicidal patients is a common practice. Mass shootings are in the headline news, and I hear about them more than any other type of gun violence, so mass public shootings must represent the highest proportion of deaths caused by guns. And if only we had gun laws targeting people with mental illness, we would effectively curb gun violence. I repeat, these are just some of the publicly held notions that have been expressed pretty widely and that I wanted to explore. So it feels like I've grown up in an era of public gun violence in the news and borne out in some ways by data, and I wanted to give a few historical references that have stood out to me. Columbine was a mass school shooting, which is now almost synonymous with school shootings that occurred in April of 1999. I was in high school at that time, and the event created a rough template that's been imitated numerous times. Jumping ahead, when I was still a medical student and told an attending physician, I was a medical student in New York, I told her that I was moving to Maine. Her response was, "Ooh, there are a lot of guns in Maine." And she didn't elaborate on that, but the impression I had from that comment was that there would be a lot of gun-related risk and harm. And I've been curious about the accuracy of her statement and what the ramifications are of a high level of gun ownership. And then on a day in mid-November a year ago, I felt like I had an epiphany. It was as typical for the news. There were two well-publicized shootings that were elsewhere in the country, and I felt as though my expectations changed from, wow, that's a terrible and distant tragedy, to, wow, these shootings are happening all the time, everywhere. When will I or someone I know be a victim? That was a really scary thought, and it prompted me to look into this topic. So I included the timeline at the bottom here, which I thought did a nice job showing that mass shootings virtually pepper the more recent portion of the timeline as they've become more frequent. So moving into epidemiology, where are the guns? To speak to that attending's comment, there are lots of guns in Maine. This is data from Columbia University and shows the percentage of U.S. adults age 18 or over who own a gun as of 2015. In Maine, 22.6% of people own guns, tying Massachusetts. And to my attending's point, it was indeed over double the ownership seen in New York State. Regionally, though, New England has lower gun ownership than other parts of the country. And gun ownership is highest within the continental U.S. in the South and Rocky Mountain West, as you can see, and highest of all in Alaska. So who owns guns? Well, a lot of people. 30% of Americans own one or more guns. 42% of Americans live in a household with a gun, which is the highest of any country in the world. There are now over 120 guns per 100 people in the United States, which is up dramatically from 88 guns per 100 people in 2011. Pretty rapid and substantial shift. That's according to the Small Arms Survey. The most commonly cited legal reason for gun ownership is safety or personal protection, according to 63% of gun owners. This is the reason that following shooting events, gun sales tend to skyrocket, as has been described in the news recently. To the contrary, though, gun ownership doesn't actually make a person safer. Ownership of a gun, on the whole, tends to increase the likelihood of dying of homicide, suicide, or accidental injuries. These are the categories of gun violence that cause physical injury. There's suicide and various types of homicide that include everyday violence related to conflicts, gangs, crime. There are domestic shootings, unintentional shootings, police-involved shootings, and mass public shootings. Nationally, 43,375 people die by guns in the U.S. annually over a 4-year rolling average from 2018 to 2021. This pie chart shows the proportion of gun deaths by intent in the U.S. Nearly 60% of gun deaths were suicide, as shown in the darker green. 40% roughly were homicide, and around 1% each were police shootings, accidents, or unclear causes of death. And for me, this was really startling that suicides by firearm were such a large proportion of gun deaths, 60% nationally. Comparing the U.S. to Maine, in Maine, 163 people die by guns annually. There were fewer than 10 police shootings, undetermined causes, and accidental deaths per year, so the CDC suppressed those data. But as you can see, there's some really striking differences. Suicide by gun, in the dark green, exacts a far higher proportionate toll than homicide in Maine. 90% of gun deaths in Maine is suicide. The suicide rate in Maine is 21st highest in the United States. By contrast, Maine, at least until recently, has the lowest rate of homicide in the United States. This is in keeping with observation that there are generally higher rates of suicide in rural areas of the country and higher rates of homicide in more dense urban areas. This shows the rate of suicide, homicide, and overall gun death have been increasing over the past 10 years. And this is a rate, not just sheer numbers. And this shows a timeline of mass public shootings. And mirroring overall gun deaths, we can see that the frequency of mass shootings is also rising. As a proportion of all homicides, deaths by mass public shooting is actually a very small proportion, but nonetheless increasing. To demonstrate how low the proportion of mass shootings is to the total number of homicides, we can look at some numbers. The Gun Violence Archive reports that mass shootings peaked in 2021 with 686 shooting events. In 2022, there were slightly fewer, 646 mass shootings. The mass shootings in this tabulation are events defined as the following. There are a minimum of 4 victims shot and either injured or killed, not including the shooter, who may have also been injured or killed, but 4 people shot at and injured at least. So of those 646 events, 36 were events in which at least 4 people were killed, not counting the gunman. Of these, 7 were mass murders in a public setting in which the murders are not attributable to any other underlying cause, such as criminal activity or a common circumstance like a robbery, argument, romantic triangle. Across those 7 events, 58 people were killed. So to put that in context, on average, 270 people are hit by lightning each year in the United States. And so although there's a staggering amount of injury and death attributable to firearms, as I had just discussed in the last slide, mass public murder is actually somewhat rare, with more people hit by lightning. Giving further context to the overall toll caused by guns, though, I want to compare the number of lives lost due to suicide and homicide as compared to the other leading causes of death in the United States. And this chart is the top 20 causes of death across all ages, according to the CDC in 2020. Suicide and homicide are both among the top 20 causes of death. And in fact, until the emergence of COVID, suicide had been the 10th leading cause of death in the United States. As of 2020, suicide had moved to the 12th leading cause of death, and homicide was the 16th most common cause of death. Over half of suicides and nearly 3/4 of homicides are caused by guns. So if firearms were a standalone column, they would also definitely be among the top 20 causes of death. This chart here shows the top 5 causes of violence-related injury leading to death. And I've highlighted deaths due to firearms. As you can see, they're near the top of the ranking, and suicide is in red, homicide is in orange, just to demonstrate that guns are the method used in the most common causes of violence-related death. Homicide and suicide involving guns are leading causes of death across all ages from 1 up. This chart here shows that firearms are more deadly than any other cause for American children and teens. More so than motor vehicles, poisoning, and cancer. And firearms are a substantial contributor to overall decreasing life expectancy in the United States, a trend that's been going on for a few years. The high rate of gun homicide is a somewhat unique American problem. Our rate of homicide is 26 times higher than that of other similarly developed rich countries. Propelling this difference is the United States, with less than 5% of the world's population, has 46% of the world's civilian-owned guns. In case anyone feels untouched by gun violence, I would say that at the very least there's a societal cost. Maine is fairly average, numerically here, with gun violence in the state costing $1,712 per resident annually. And it's certainly not value added. The cost is comprised of the categories seen here. There are medical care and mental health care costs, legal costs, including police work, court costs, incarceration, quality of life due to pain, decreased well-being. Employer costs come from lost productivity of people who are harmed or family members, decreased revenue, and then there's lost income by people who are injured or killed. So as you can see, the financial effects of any shooting ripple well out beyond the shooter and the victim to our entire society. Briefly, some demographics of who is afflicted by gun violence. White people are 3 times more likely than Black people to die by gun suicide. The vast majority of suicides by gun are white, non-Latino men who tend to be older. American Indian men, in fact, have the highest suicide rates of all. Black people are 10 times more likely than white people to die by gun homicide. Individuals in gun-owning homes have at least 5 times greater risk of death by suicide, and that risk is higher when guns are stored unsafely. So to discuss mental illness and how it relates to gun violence, it's important to know the prevalence of mental illness as a starting point. Lifetime prevalence of any diagnosable mental illness in the United States is 46.4%. Approximately 20% of the US adult population experiences a mental illness and seeks treatment in a given year, and nearly a third of Americans do so in their lifetime. 5.5% of adults in the US experience serious mental illness, causing disability defined as a mental, behavioral, or emotional disorder resulting in serious functional impairment, which substantially interferes or limits one or more major life activities. Serious mental illness typically includes disorders such as bipolar disorder, major depressive disorder, and schizophrenia. So how much violence towards others might be attributable to mental illness? Several epidemiological studies have tried to answer this question. They've found a small but statistically significant association between serious mental illness and violence. One found that 12% of people with serious mental illness had committed a violent act within the past year, compared to 2% of people without mental illness or a substance use disorder. Among people with serious mental illness but without comorbid substance abuse, 7% had committed a violent act in the past year. Extrapolating, the study authors estimated that 3 to 5% of violence of all types, not just gun violence, in the United States may be due to mental illness. Another study found that the percent of violence perpetrated by people with serious mental illness but no substance use disorders was very similar to the percent of violence perpetrated by people with substance use disorders but not serious mental illness. Meeting both of these conditions, serious mental illness and substance use created the highest risk for violence. It's certainly important to say that the majority of people with mental illness, including serious mental illness, are never violent, and people with serious mental illness are more likely to be victims of violence than to perpetrate violence. When it comes to the small proportion of all violence which could be caused by mental illness, there are some frequently seen psychiatric symptoms that have a higher correlation. This list, which is not comprehensive, includes first break psychosis and psychosis in general. It's a particularly vulnerable time for violence. Among people experiencing a first episode of psychosis, 1 in 3 had exhibited some form of violence before entering treatment, and 1 in 6 had committed a serious violent act. And after a first episode, psychosis at any time confers elevated risk of violence. For instance, a person experiencing psychosis can misunderstand or misinterpret the environment. Hallucinations, and in particular command auditory hallucinations, can promote violence. Paranoia that someone is going to be harmed may lead to a violent response in self-defense, and disorganization may impair thinking and judgment. Also, lack of remorse, for instance, seen in antisocial personality disorder, irritability, anger, desire for retribution, impulsivity, seen in many psychiatric conditions, intoxication, and suicidality are all symptoms or conditions associated with increased risk of violence. Independent of the risk factors on the last slide, there are many other factors that increase risk for violence far more than mental illness. So these should all be highlighted. Past history of violence is one of the most highly correlated risk factors for future violence. Substance use disorders also significantly elevate violent behavior. 46% of Americans with serious mental illness have comorbid substance abuse or dependence within their lifetime, compared to only 15% of the overall US population. Additional risk factors include youth, male gender, low socioeconomic status, trauma, and abuse and neglect. Extensive trauma is common in the serious mentally ill population and contributes risk, as does violent victimization, family dysfunction in youth, exposure to neighborhood violence. Bad things, such as childhood abuse, have typically happened to people who do bad things to other people. Many people with serious mental illness are disadvantaged and marginalized throughout their life and exposed to many of the risk factors that are associated with violence. So is it possible to predict violence? Well, if it were possible, I wouldn't be giving this talk because action could already be taken. But one problem with prediction is that rare events are inherently hard to predict, And when it comes to mass violence, particularly mass shootings, we're talking about rare events. There are numerous structured risk violent assessment tools, which are sometimes used to help identify people at higher risk of violence. They're most commonly used in forensic settings, but occasionally in emergency departments. In a meta-analysis of commonly used risk assessment tools, the median positive predictive value was only 41%, meaning that of people who were thought to be high risk for future violence, only 41% went on to do a violent act. On the other hand, in this meta-analysis, the median negative predictive value was 91%, meaning 91% of people who were deemed low risk to commit an act of violence did not. Therefore, we can see that screening tools are fairly good at identifying who is low risk for perpetrating violence, but not for predicting who will commit violent acts. Even though we can't use these tools to predict violence on an individual level, they are useful in prevention of violence. They can be used to create risk assessment tools for each individual so that more interventions can be targeted at those who are high risk and fewer to people who are at low risk. And risk management strategies can be increased or decreased depending on the need at reassessments in the future. On a population level, firearm risk reduction strategies should be narrowly targeted, for instance, at subgroups of people with serious mental illness who are at high risk for gun violence, likely manifested by past violent acts or other things that are highly correlated. So just to distill the association between mental illness and violence, small subgroups of people with serious mental illness are, at certain times, at heightened risk of committing violence towards others. However, only 3 to 5% of all violence is attributable to mental illness, including gun violence. And therefore, 95 to 97% of violence is not attributable to mental illness. The vast majority of people with mental illness are never violent, and most instances of violence with serious mental illness do not involve firearms. Therefore, focusing gun restriction laws on people with mental illness is not an evidence-based approach. Other risk factors, especially substance use and past violence, are far stronger predictors of future violence than is mental illness. And by comparison, mental illness increases risk of suicide, which accounts for 6 in 10 firearm deaths. So certainly, suicide is highly correlated with mental illness. So at this point, I just wanted to revisit the last slide listing types of gun violence to give a visual depiction of the relative magnitude of each type of gun violence and how it affects people. Suicide by firearm is far and away the largest cause, and all the more so in Maine. So having found that suicides cause the majority of gun deaths nationally and here in Maine, it's important to focus my discussion on elements of suicide. I want to begin by highlighting how pervasive suicidal thoughts and acts are. In 2020, 12 million adults had serious thoughts of suicide. 1.2 million attempted suicide and nearly 46,000 died by suicide. Of the suicide attempts that were identified and brought to medical care, 8.5% were lethal. Of course, many times suicide attempts are not brought to medical care and not recognized. These here are the most common causes of death by suicides. Firearms lead to over half of suicides, as you can tell, and they cause roughly twice the deaths by suicide of the next most lethal method. Firearms and hanging together accounted for only 8.8% of suicidal acts, but caused over 3/4 of deaths. And I say that just to point out that together they represent less than 10% of all suicide attempts, but cause 75% of fatalities. This slide shows the relative lethality of various methods of suicide, and we find tremendous variability in the case fatality ratio, which is the percent of suicide attempts that by a given method which result in death. And firearms are not the most common method of attempting suicide, as you can imagine, but they are the most lethal. Approximately 9 in 10 attempts using a firearm end in death. I'd like you to take note of the fourth line, which is charcoal burning, because I'll reference that in a moment. And also at the bottom of the list, poisoning, which includes overdose, something we probably commonly see. I certainly do, has a very low case fatality ratio with only about 0.5% to 2% of attempts using that method resulting in death. So suicide is a major public health concern, if not a catastrophe. More than 125 people kill themselves daily in the United States, and over half of those are with a gun. In a large pooled study, the risk of suicide was found to more than triple in homes with a gun. Suicide is very much correlated with mental illness. The risk of suicide is increased by a factor of at least 10 across a range of psychiatric diagnoses. And most people who attempt suicide have a mental illness, most commonly depressive or anxiety disorders. There are a few arguments to be made for restricting access to lethal means, particularly during a time of crisis. Suicide is usually impulsive. For many suicidal crises are brief and fleeting. Survivor studies show that many people who reported a suicidal period of less than 1 hour, and many moved from thinking to acting on their suicidal impulse in only 5 to 10 minutes. Only a slim minority of survivors had been thinking about committing suicide for 8 hours or more. The methods used for suicide attempt depend on their availability, at least as much as on the perceived lethality of the method. So if something's easy, it's what people tend to use. It explains why poisoning by overdose is the most commonly used method of suicide, even though lethality is rather low. Medications and poisons are readily available. The third argument for restricting lethal means is that prognosis for someone who survives a suicide attempt is good. Among those who have survived suicide attempts, fewer than 10% go on to die of suicide. So it's clear that saving someone's life now is likely to save them in the long term. If firearms are restricted, do people simply find another method to suicide? Typically not. Many studies have looked into this. Ecological studies have found that in states where gun ownership is the highest, suicide rates by gun and overall suicide rates are high. And in states where gun ownership is the lowest, suicide rates are much lower, and the proportion of suicides by methods other than gun are not significantly elevated, which says that people aren't simply finding an alternative method of suicide. Unlike recent years, there was a time in our country where gun ownership decreased. From 1981 to 2002, there was actually a nationwide decrease in gun ownership per household. During that time, there was a significant decrease in the suicide rate without any major change in prevalence of mental health or suicidal ideation. And case control studies have shown that the relative risk of suicide when guns are in the home increases between 2 and 10-fold, depending on the age of people in the house and storage techniques. As you might imagine, less safely stored guns elevate risk to the higher end of that spectrum. A cohort study in California, residents purchasing guns from licensed dealers showed that their risk of suicide more than doubled at the time of purchase and over a 6-year period. There are three really striking international examples of reducing suicide risk by lethal means. And we have to look at other countries to find this. In the UK, from the 1960s to the 1970s, the heating source for domestic ovens was converted from coal gas to natural gas. And coal gas contains a lot of carbon monoxide, which is a lethal gas, whereas natural gas has nearly no carbon monoxide. Over that roughly decade-long period, the suicide rate decreased by 30% just by changing the gas in the ovens, and has been steady since then. An even more dramatic example comes from Sri Lanka. Beginning in the 1990s, there was a series of bans on highly toxic pesticides, and these changes cut the suicide rate in half. In half. This occurred in the absence of any other interventions to reduce suicide, and doing so did not cause any noteworthy increases in non-poisoning suicides. In Switzerland, there's actually a high rate of gun ownership, nowhere near that of the US, but higher than many countries, because the Swiss army had been a militia based on mandatory conscription of all men between ages 18 and 43. Men were issued guns, primarily rifles, and those were available for purchase at the time they had finished their military service. suicides were found to often be completed by gun in that country, and 40% of firearm suicides were with Army-issued rifles. In 2003, though, a change in law allowed people who did not want to participate in the Army there to the opportunity to do civil service instead. So the number of troops was reduced by over half in a 1-year period, and with it, suicide by firearm was abruptly reduced. So these large population-based examples show that restricting access to lethal means does not simply push people to find alternative means to suicide. In the commonly fleeting and impulsive act of suicide, people reach for what's available, so temporarily restricting access to lethal means is an effective way to prolong life. Now, turning to homicide, I'm most interested in the outsized role that mass shootings play within our collective consciousness. So even though I learned that mass shootings represent a small proportion of overall gun violence, it still contributes to many deaths, and I wanted to review some of the salient aspects. Mass shootings by people with serious mental illness represent less than 1% of all yearly gun-related homicides in whole. In a study pooling data from 6 observational studies, the risk of homicide was found to double in a home where there is access to a gun. So while it may feel safe for people to possess a gun, the risk of someone shooting someone else in that home doubles. Regarding the mechanism used for homicide, CDC data show that firearms are the method used in nearly 3/4 of homicides. So again, guns are a very lethal tool. Is there a link between mental health and gun violence? Research suggests that in the absence of substance use disorders, there's a minimal relationship between psychiatric disorders and violence. Therefore, assuming that people with mental illness are high risk for violence lacks evidence. There is a slightly elevated risk of homicides by people with schizophrenia, but the rate of stranger homicides, meaning killing someone unknown to the perpetrator, is extremely low, on the order of 1 stranger homicide per year per 14.3 million person population. So extrapolating that data to the entire United States, there might be 23 of these in a year, making it 15 times more likely that a person would be struck by lightning than being killed by someone they do not know with schizophrenia. Not many mass shooters have been in psychiatric treatment for serious mental illness, and instead of being those who are treatment failures or fell through the cracks, mass shooters are often people who have plotted killings far from mental health professionals. It's important to say before and after the next couple of slides, there's no profile of a mass shooter that can be created, and I don't want that to be suggested or implied. I'm just providing some information based on study of mass shooters. So some of the psychological aspects of a mass shooter that are more commonly seen are that they may feel aggrieved and resentful, that the world is not fair. Feeling, for instance, that I am right and I've been treated very badly. Narcissistic traits are very common. Many shooters want to be seen and feel that by killing a victim, they will have restored respect that they feel they deserved. Some, therefore, are preoccupied with revengeful fantasies, and many have a need to share a final message or a manifesto that's written or video recorded or live streamed. Many have paranoid and suspicious worldviews, but not often rising to the level of frank psychosis. However, psychosis appears to play a major role in 10% of mass shootings. 70% of the time, psychosis played no role in the shooting. The remaining 20% of cases where psychosis may have played a minor or moderate role. Most shooters have a slow build towards the crisis point that's found, and the shooting is not simply an impulsive act, but rather a well-planned one. A third of shooters are actively suicidal. It's important to know, and mass shooting can often be seen as an angry suicide. Psychopathy is not an apt descriptor according to experts, as psychopaths are typically charming and glib and would not suicide. These shooters are neither charming nor glib, most commonly, and more often than not plan to suicide or at least die in the act. Some points about these characteristics to set some records straight that I anecdotally hear about shooters is that they are all angry white men. It is true that nearly all shooters are male. However, only about half are white. Most are born in the US, but not all. military experience is overrepresented, with 27% of shooters having had military experience, compared to 8% of the US population having had military experience. 59% have any mental illness history, a percent that is not actually substantially above the percent lifetime prevalence of any diagnosable psychiatric condition within the US. So it's certainly not a very specific risk factor. The majority, though, most importantly, have a history of violence. And the majority of younger shooters tend to leak their plans, telling other people via text, polls, posts online. One resource I used to better understand what leads to a mass shooting is the Violence Project, which is a database compiled by a psychologist and a sociologist based on their research of 189 and counting mass shootings since 1966. They examine lives and motivations of the mass shooters and argue that mass shooters are typically not primarily mentally ill, but rather ordinary people who have been driven to violence by a combination of factors, including childhood trauma, with numerous adverse childhood experiences, anger, and social isolation. In this setting, they tend to fixate on people or groups they blame for their miserable circumstances. Online communities readily provide validation and a place to become more radicalized. They reach a crisis point in the days, weeks, or months prior to the violence. Most shooters reach a crisis point which pushes them over the edge. This could be a job loss or being reprimanded, for example, or a relationship ending, or interpersonal conflict. And it's often identifiable and often evident to the people surrounding the perpetrator via behavior change or even overt discussion of a plan to harm others. And I think this echoes from what we've been hearing lately about recent events in Lewiston. And people surrounding the person often don't know what to do or don't expect them to actually commit a violent act. Mass shooters often become suicidal. And as I said, mass shooting is often an angry form of suicide. There's a media contagion surrounding these events. Mass shootings are always covered extensively in the national media, whereas shootings with fewer than 4 victims are typically covered locally. This coverage can give other people the idea to commit similar acts of violence and also provides a lot of information and potentially a template to follow. And access to firearms is, of course, essential, and this is relatively easy. Most shooters do not commonly have criminal records prohibiting them from purchasing guns, and so most have purchased the guns legally. Young shooters often take unsecured guns from family members. So it's important to stress that these are not causal features of a mass shooting, but they're highly correlated with mass shootings. So no two shooters are alike in their psychology and motivations when it comes to mass shooters. These are some of the most common motivations for mass shooters. There's some overlap between these, so they don't add to 100%, but domestic issues or relationship difficulties, employment issues, interpersonal conflicts, hate towards a group, for instance, psychosis may play a role, legal issues, fame seeking. Turning to places where lethal means have been modified in the wake of a major mass shooting, it can be helpful again to look outside the United States because not much has been done here following mass shootings. Australia is a country with a big gun culture, much like the US. And after one particularly devastating mass shooting in 1996, in which 35 people were killed and another 23 were injured by a lone gunman, within 12 days, the Australian government, led by a conservative prime minister, banned semi-automatic rifles, automatic guns, and shotguns, and did a buyback of all such privately owned guns. They required standards for firearm security and storage, and they began a national registration of all firearms. And what's the outcome? In the preceding 18 years, they had nearly 1 mass shooting per year. Since then, there have been none. Additionally, all gun deaths, meaning suicide and homicide, decreased substantially, saving approximately 200 lives per year, in a country with only about 1/13 the population of the US. Interestingly, with the buyback, there were differential levels of buyback in different Australian states. Those states with higher levels of gun buyback had lower rates of gun death in subsequent years, and vice versa. In states where fewer guns were bought back, firearm death rates remained elevated. Extrapolating to the size of our population, if we rolled out similar laws, we might expect to save 2,600 lives per year. 20 years later, following an attack in New Zealand that left 51 people dead within a very short time, the parliament there acted nearly unanimously to outlaw military-style semi-automatic weapons, assault rifles, and some gun parts. And enforcing this by having violators face prison time. And a buyback at that time was used to collect 56,000 guns from civilians. Domestically, changes in requirements for gun purchases gives us a way to compare the effects of tightening or loosening restrictions on gun purchases, either by imposing a wait period prior to a purchase or implementation of a permit in order to purchase a gun. And without inundating you with numbers, across numerous states and studies, what is seen is that waiting periods prior to purchase or permitting requirements cause firearm suicide rates to decrease, typically around 15%. And rates of firearm homicide decrease between 10 and 40% without driving people to alternate methods of suicide or homicide. So really sharp decreases with mild restrictions or slowdowns on the availability of purchasing weapons. It's likely that without media coverage, there will be fewer mass shooting events. In addition to getting a sense of revenge, many mass shooters hope they'll be given a platform, posthumously perhaps, to share a manifesto or restore honor. And the saying, if it bleeds, it leads, really plays to a need that we as a society and audience have when tuning in to learn about serious events. There's a captivating element about the horror of an event, and then we hope that by continuing to watch, we may learn something that would be actionable to help us be safer or prevent future events. But in fact, neither of these things tend to happen. In fact, there's a reinforcing effect. The size of each shooting helps determine the level of a contagion effect that follows larger events with more dead or injured, as well as school shootings in particular, are covered nationally. And by comparison, when there are fewer people dead, or it's not a school shooting, the coverage tends to be regional or local. Mathematical modeling has shown there's a contagion effect following school shootings, and for shootings with 4 or more people dead. In light of this, responsible reporting guidelines have been created to avoid sensationalizing the killer or giving the shooter's ideas a platform. Media reporting is evolving, and these days there's less coverage of serial killers because there's less celebrity factor, and the rate of serial killing has decreased from a height in the 80s. By contrast, there's more coverage of mass murders, and the rate has been increasing. Media is not perfect, and some of the greatest harms come from people who have great influence, saying that mental illness makes people prone to violence, or that more guns in the world would make people safer, or there would be fewer gun deaths if more good guys with guns were stopping bad guys with guns. But all of these theories have been studied, and there's not credible evidence backing any of these concepts. But it does not stop them from being widely shared. So as I begin discussing clinician guidance, I want to take a step back and make it very clear that it's not possible to accurately predict gun violence or gun violence. And so it's not with a goal in mind of creating a profile or a mass shooter that I shared this information. It's that really is the realm of forensic psychiatry and using violence risk assessment tools. And even with the time they dedicate through screening tools, prediction is imprecise. And a better goal is using our knowledge for violence prevention. So I want to discuss some of the best and evidence-based ways to engage patients in discussions about gun safety. First, you might have legal concerns about discussing guns, and there's no doubt that the Constitution bears a right to guarantees a right to bear arms. It's been reaffirmed many times. However, discussing gun safety with patients and documentation of conversations, if you prefer to do that, has been contested in certain states and ultimately reaffirmed that we can do this. Maine has a yellow flag law, which is, I'd say, a watered down version of a red flag law. The way the yellow flag law works here is that law enforcement must have a probable cause to believe that a person is a danger to themselves, typically either by a family report or someone else reports it to law enforcement. They can take a person into protective custody and have them evaluated by a medical professional. If that medical professional deems them a threat, then that has to be transmitted to a judge, who then must order a temporary removal of firearms. In the Portland area, I know that patients can be brought to the emergency department at Maine Med and probably to other emergency departments. And the state has a contract with Spurwink to do the yellow flag evaluations remotely via telehealth. So comparing a yellow flag law to a red flag laws eliminate the need for a medical examination, and an application for extreme risk protection order is submitted to a judge who will review and decide if it makes sense, and can on the same day issue an extreme risk protection order. And then police immediately remove the guns from the respondent and bar them from purchasing guns, at least until a hearing, typically within a week or two. Maine's yellow flag law was enacted in 2020, and as of earlier this year, it had been used 45 times. And the challenge really is the extra step of having a medical evaluation, and it puts a medical practitioner in a role as an arbiter of whether a patient could be in possession of weapons. And it's inherently difficult to do that. So it's a fraught position, certainly potentially disruptive to the therapist-patient relationship, and not a position that most providers of any sort want to find themselves. But that's the current state of law in Maine about yellow flag laws. So is discussing firearms my job? Well, that's something I want to discuss. Discussion of gun safety is certainly an opportunity to address one very common health risk. As we've seen, suicide is nearly a top 10 cause of death, often seen with mental illness and often performed with guns. So I would recommend a discussion of guns and gun safety. The American Psychiatric Association and the American Medical Association do have guidelines that recommend physicians talk about with patients about firearms and provide appropriate counseling. I wasn't able to find any clear guidance from the American Psychological Association regarding speaking to clients about guns. I was able to find some guidance from your APA, the American Psychological Association, about word choices, how not to alienate clients. For instance, it might be better to use the term firearms rather than guns, just because it sounds more clinical and less judgmental potentially, to not use the term restrict and focus on voluntary and temporary nature of safer storage options for guns. And a recommendation was made to consider when to bring up firearms, certainly before a crisis occurs, particularly in the context of suicidal ideation, changes in behavior, or symptoms of depression, agitation, insomnia. Studies have shown that conversations around firearms are actually productive and do lead to safer behavior around guns. For instance, locking guns or temporarily restricting access during times of crisis. Meaningful conversations cause meaningful change. So, starting a conversation with your patient could be the same as any topic, any other potentially sensitive topic. Clearly, with respect for the background and view of each patient. I mean, our patients, our clients own guns. We may own guns, and we need to respect that. And the purpose is really to convey a sense of the safety and wellness as an objective. And as you might imagine, most gun owners are already committed to gun safety. So some examples of non-accusatory types of questions that you might ask is, some of my patients have guns at home, and some gun owners with suicidal thoughts choose to make their guns less acceptable. Are you interested in talking about that? Do you have any concerns about the accessibility of your gun? You might extend that, especially with who's in your household, children, potentially other vulnerable groups. It may be a life-saving measure to screen for suicidal and homicidal intent and plans, so continue to do that, or if you don't already, I certainly would start. From there, discuss safe storage of firearms, and this is doubly important for when there are children in the house, as I mentioned, or if someone's suicidal or homicidal. or if they have altered mental status. For instance, if there's someone in the house with dementia, um, or subsets of people with serious mental illness, particularly those with past violence. And safe storage doesn't have a universal meaning, but safer ways of storing weapons are typically locked up in a safe or with trigger locks, or potentially unloaded with ammunition stored separately and away from the gun. Or for people who have elevated risk of suicide, it's probably best to store any firearms outside of the home, such as with family or friends who live elsewhere, or potentially even with police. The 5 Ls is a simple mnemonic to do a brief safety review with patients who are in homes with guns. There's L for locked. Is it locked? Is it loaded? Is the second L. L for little children. Are there little children present? Are you feeling low? And learned operator, or learned. Is the operator informed about gun safety? Those are 5 Ls. Another method for discussing firearm safety is called lethal means safety counseling. And this is a chart that shows what it's all about. It's a process to determine the type of risk your patient may be at. For instance, increased suicidal ideation, or risk based on past violence, or based on a demographic group. For instance, older white men tend to be high risk for suicide. And then providing a targeted response in your work with them, and potentially also with their family and friends, depending on the need, to reduce risk and potentially access to lethal means until the risk has decreased. So to use this method, you would identify patients for whom these conditions apply, shown in the left-hand column, and proceed selectively. So it needn't be a lengthy intervention or debate. And so the first category there is acute risk, which presents an obvious emergency, and it's important to react appropriately. The second is for patients with risk factors for future violence, and we've discussed some of these already. And the third is for demographic groups that are inherently at increased risk for firearm-related injury. And it gives some examples and recommendations of how you might use this. It feels self-evident to say treat all patients as clinically indicated and provide care as you usually would. And most suicides are in the setting of mental illness, so providing the best care for those conditions is advisable, including referral for higher levels of care or medication management if you believe it's necessary. There's strong evidence for psychotherapy reducing violence risk. Evidence shows that the rate of violence decreases with antipsychotic medications for psychosis. Engagement with the medical system and even just possession of medication is helpful. And therapy, as I just said, reduces violence. So what could you do when something a patient says worries you? Well, you might feel ambivalent. It might be good to talk to a colleague or find an ethical group, potentially where you're trained. And it may be important to reach out to others, including law enforcement. If you're referred someone who's been found in the planning stages of violence, the risk assessment really should be referred to a forensic specialist. When it comes to information that must be reported, there's an obligation for all healthcare providers to warn a potential victim of a patient's threats. That's the Tarasoff rule that you may be familiar with. And you can do that by either warning the victim of the threat, informing law enforcement of the threat, or hospitalizing the patient. Sometimes easier said than done, but it's a duty that we have. You are not required to warn the victim if doing so would put you or the patient at risk. If a healthcare provider fails to warn or protect, though, a potential victim and the victim is injured or killed, the healthcare provider may be held liable for negligence. It's a law that applies to all healthcare providers, including psychotherapists, and it applies to all threats of violence, not just threats of homicide. It does not require you to predict the future. You only need to have a reasonable belief that a patient poses a serious threat of violence. And so, although it's uncomfortable to share protected health information, you are protected from civil or criminal charges when you share information appropriately. So that was the information you must share. In Maine, you may share the following information, that which could prevent or mitigate a serious or imminent threat to the health or safety of persons, of a person or the public, or to report a suspected crime, or sharing information with parents of minor patients. So beyond the workplace, what might be done? Well, when it comes to policy, I think it's great for us to speak up when there are opportunities to increase safety and improve mental health opportunities. For those inclined to use firearms, if that's any of you, you might consider working with local gun clubs or arms dealers, offering education, guidance, partnership. Where possible in your life, use your information and really influence to contradict false statements which stigmatize people with mental illness. Data show that people with mental illness were more stigmatized in the late 90s than they were back in the 50s, and statements creating false associations between mental illness and gun violence harm our patients. And so I'd like to aim for an uplifting conclusion, but sometimes it feels like a challenge in the context of gun violence. But I want to reinforce the point that locations with more guns are locations with more gun deaths. And places where suicide rates are higher are not places with more mental illness or places with where people spend more time thinking about and planning suicide, but they're places where more Americans live with firearms. The good news is we're able to help. Don't shy away from a discussion. Opening discussions with patients about firearms is not a widespread practice, but it has benefit, particularly to people in crisis. And the world of mental health needs more of us in it, reaching people, reducing isolation, starting conversations. And the most effective thing we can do is insist on safe storage of firearms and temporary removal in times of crisis. I have a bunch of citations, and that is a wrap. And now I get to see you all. Ha!
Fantastic. Thank you so much, Robbie. And I did want to add that the intake paperwork that Robbie helped develop for psychiatry does have an item on it that asks specifically about ownership of firearms and storage of firearms. And we are adding that to the psychology paperwork as well. So that's a great prompt for you to be able to have a conversation with patients. So thank you, Robbie. That was really informative. Thank you.
Good. Happy to be here. Does anyone have any questions or comments?
I was curious, with this knowledge that you've shared with us, how has it been to listen to the reporting in Maine about mental health and guns? And I'd just be curious for a comment or two from you.
Gosh, I have so many feelings. It's disappointing that with what appears to be numerous opportunities for sort of intervening and intercepting, that the yellow flag law wasn't effectively deployed. And it seems like that could have made a really big difference. And it's, it's sad, and it's not a blame game, but where is it? It's as I said, watered down compared to a red flag law. It's difficult to do. And it doesn't, and yet it's what we have available to us. So I think it's something that if we meet patients like that who really do concern us, it's something that it sort of behooves us to reach out and take action.